Type it up. What's the mechanism? How do they give high blood pressure? Type it up, folks. What's the answer? When the cortisol is really higher than normal, they work like aldosterone. That's what we studied. The alpha-1 upregulation is under physiological level. Does that make sense for? I repeated that 3 times so far. So when you are a normal person, your cortisol works like, it upregulates alpha-1 receptors. But when they are pathologically high level, they work like aldosterone, isn't it, folks? That's exactly what's happening here. Cortisol activates mineralocorticoid receptor. So they are literally working like aldosterone. So now this is also going to present like a hyperaldosteronism because they are working like aldosterone. Is that clear, folks? They are also hyperaldosteronism. Look at that. Metabolic alkalosis, hyperkalemia, hypertension, decreased serum aldosterone. Okay, same story, folks. The only difference, the patient has increased cortisol, so you will have other symptoms of increased cortisol. Okay, increased symptom. In this diagram, I could actually add that too. That also has, this one disease we talked about here. You see, decreased serum aldosterone, right? Decreased serum aldosterone, decreased renin, because the mineralocorticoid receptor is the one that, cortisol is the one that functioning in the receptors. Does that make sense, folks? Okay, this disease is called syndrome of apparent mineralocorticoid excess, which makes sense. How do you get excess mineralocorticoid? It's basically the cortisol is working on the receptors. Is everybody clear, folks? The cortisol is working on the receptors, right? Now, people get this, if they eat this candy, licorice. Apparently, licorice candy has a lot of this effect that it inhibits if you eat a lot, okay? And that's the idea. So what's the treatment? You have to block the receptor, potassium-sparing diuretics. So you have to block the receptor. So we're going to give aldosterone antagonist receptors, okay, folks? And give them exogenous corticosteroid so your endogenous will slow down. If you give from outside this, the negative feedback will inhibit that. Does that make sense, folks? So that's the idea here, folks, okay? So that's syndrome of apparent mineralocorticoid excess. 100% one question in this page, okay? Now you could see this, especially Fanconi, it's connected to so many diseases, folks, okay? But do not confuse Fanconi syndrome versus Fanconi anemia. That's another disease. It starts similar, okay? Fanconi anemia is different, Fanconi syndrome is different. So what is Fanconi anemia now? There's a defect in the DNA break, did not repair, the cell get arrested. That's an aplastic anemia, isn't it, folks? That's an aplastic anemia, folks. Okay, very good. So that's Fanconi anemia. This is Fanconi syndrome. That all take care of here, your renal tubular defects. Is everybody clear? All right, let's go to the next page. Now, this is a memorizing chart, but we could understand something here. When the number is 1, it tells you the solute and waters are reabsorbed at the same time. When we say solute, that means sodium, anything that has a value, okay? Sodium, potassium. Now look at this. Sodium and potassium and water, they are all same importance. That's what number 1 means. Sodium, potassium, and water, they are equally important, so they're both reabsorbed at the same rate. As the number goes down, your water is not important anymore. Look at this. When the solute is reabsorbed more quickly than water. So as the number goes down, we do not give importance to water. Is that clear, folks? So that's the idea. Less than 1, more reabsorption of solutes. Look at this. bicarbonate, amino acid, glucose. Isn't it? We almost reabsorb 100%. Look at that. That's why amino acids and glucose 100%. This is almost like 90%, a little bit more or less, but they all reabsorb, folks. Okay. When the number goes more than 1, they are giving more priority to water. So water is more important than the solute. Now look at this. PAH, creatinine, urea, we excrete all those things, isn't it, folks? So here we reabsorb the water and we are excreting all these things. At the end of the day, what do you need to know? They will put A, B, C, D, E, F, G, and they literally ask you, what does that letter stand for, folks? Okay, that's that question. Like, if you want, I could show you one question quickly. Let's see. So let me pull one question here. Yeah. Look at this question. This is literally an NBME question. They're asking what is number 2 and number 4. Okay. If you are confused above 1, there are so many. At least number 4 and 5 has to be one of those 3 things: bicarbonate, glucose, amino acids. But I know number 5 is glucose and amino acid because they almost reabsorbed everything, isn't it, folks? So what is number 4 then? Bicarbonate. Okay, that should be bicarbonate. If you know 1, then you will get the other one. Because number 4 is the second letter out of all these things. You only have E that matches with it. Is that clear, folks? So that tells you number 2 is urea. Okay, number 2 is urea. You see, it's a pure memorization, folks. Look at that. That's what they want you to know. Okay, so but at least less than 1 means what, more than 1 means what, folks. Okay. All right, buy one, get one free. Let's try this. I want the diagnosis if possible. I shouldn't have done it, but it's okay. Let's try it. Because they involve renal tubular acidosis, but you still should be able to get. What's the diagnosis, folks? At least where's the problem? What tubule is this? It's a proximal tubule problem, isn't it, folks? Because they are bringing glucosuria, right? So we could rule out all those things. Now we have 3 option proximal. The problem should be E here, folks, reabsorption of bicarbonate. If you think this is a Fanconi syndrome, that's a reabsorption problem, not the secretion problem. Is that clear, folks? All right, just to kind of know, that's a Fanconi syndrome. They're bringing renal tubular acidosis. It will make sense when we do that disease, but at least the disease is Fanconi syndrome. Is that clear, folks? All right. Let's go. Okay, now here, this all review renin, angiotensin, aldosterone system, folks. Let's take a look. Now, look at this. So the JG cell secretes renin. The renin goes and converts angiotensinogen to angiotensin 1. Angiotensinogen is coming from a liver because it's a protein. Is everybody clear, folks? Okay. That angiotensin 1 becomes angiotensin 2 by the enzyme called ACE that comes from the lungs, pulmonary endothelial cells. That's what secretes ACE. And you also know ACE is important to break down bradykinin, right? Who else break down bradykinin, just to recall? C1 esterase inhibitor. They also break down, right? So just to recall. All right. Now, once you have the active form of angiotensin 2, you should know 6 functions of angiotensin II. 1, they do a vasoconstriction in most of the blood vessels, but very mild function, they could try to bring the blood pressure up, okay? The second most important, they does what they do call constrict efferent arteriole. We just talked about it today, right? That's one of the most important function of angiotensin II. They work on the efferent arteriole. Third, they also work on the PCT to reabsorb sodium. It's there in the book we covered, okay? Now, look at this. They also stimulate aldosterone. What did we say earlier? Aldosterone works on both cells, isn't it? Principal cell and intercalated cells. Look at that. They are nicely given here. They work on both cells. You know what they do, so we don't need to worry. Angiotensin II also stimulate ADH. ADH only works on the principal cell, we know that, to reabsorb water. So that's 5 functions. The last one, they make you feel dehydrated. They don't make you feel dehydrated. They make you feel thirsty, so you will drink a lot of water, so that brings fluid back to your body, folks. All these are functions of angiotensin II. Okay, so that's angiotensin II, and we have things here. The most important, that activation is decreased sodium chloride delivery to macula densa will activate, and also sympathetic beta-1 receptors. Is that clear, folks? That's your beta-1 receptors, okay? So they are all important for running angiotensin-aldosterone system, okay? This is all repetition, okay? All of them repetition here. The only thing I'm going to talk a little bit about ANP and BNP, even though we talked about a little in the heart. Now, what did we say? In the heart, when you have a physiological stretch, that actually help for the more cardiac output. Is that clear, folks? Right? Physiological stretch. What happens if your heart overstretch? Every time a heart overstretch, whenever your heart overstretch, it secretes ANP and BNP. Because every time heart overstretch, the understanding is fluid overload, which is not a good sign. Your fluid is overload in the heart. That's why heart is stretching more to pump, and that will eventually fail, because fluid overload causes decreased cardiac output and heart failure, folks, okay? So fluid overload will do it. Now, the minute you overstretch, the body tries to compensate for it by producing ANP and BNP. Are we clear so far? Now, what does ANP and BNP do? They literally inhibit RAS. What does that mean? They shut down the renin system, because renin system like to bring fluid back to the body. We don't want to do that because we already fluid overload. We don't want any fluid. We, in fact, want to excrete fluid. Is that clear, folks? So what ANP and BNP does, they block the RAS and help to excrete fluid, excrete sodium, water, and all these fluid forms. They excrete sodium, water, and fluid forms. Okay, that's what BNP and ANP does. So we use BNP also as a marker for heart failure. If you have a patient with heart failure, if you check their blood, they should be having enough BNP, because that will always release when they overstretch. Is that clear, folks? All right. Now look at this. ANP comes from atria. BNP comes from ventricles. It responds to increased volume, inhibits renin system, okay? And they try to decrease renin and increase GFR, dilates AFF. Why you want to dilate AFF? More fluid can come to the kidney, so more filtration, more excretion. Is that clear, folks? Okay, that's called promote natriuresis, folks, okay? That's the idea. They excrete. Okay. So that's ANP and BNP. Is everybody clear, folks? Okay. Then if you go here, they are still talking about JG cells. Okay, it has 2 ways to stimulate JG cell. Beta-1 or macula densa can stimulate. You see, they are repeating the same information, folks, what you know. It looks like a lot of information. No, you know where erythropoietin comes from. We convert vitamin D, prostaglandin, dopamine. All these are part of your kidney. Finally, they have given a picture that has all the hormones that are acting on kidney in like a summary here, folks. Okay, you don't even have to look at it if you already know all these things. The only thing I would pay attention, cortex and medulla in collecting that. You see that, folks? So that's the idea here. Now look at this. This and this are the most concentrated urine segment. Agree? This is in healthy. This is in dehydrated. Clear, folks? No matter what, where do you reabsorb the most water? That's here. Clear, folks? Okay. Where is the most diluted urine? Here and here. How do you differentiate? Vasopressin dependent. This is not vasopressin. Is that clear, folks? Yes? See, when you repeat, it becomes easier and easier, folks. That's all. Okay. So we pretty much want to stop here. And you want to review everything what we have done. You might feel overwhelmed, but it's not. But you see, kidney is important.